Bismillah ar-Rahman ar-Rahim. I would like to welcome you. And today, the key findings, imaging findings in the most common interstitial lung diseases and in other lung diseases. There are numerous interstitial lung diseases, but in clinical practice, actually 10 diseases represent about more than 90% of cases. Knowledge of both the radiological and the clinical appearance of these more common interstitial lung disease is important. However, there are some less common or rare diseases but have pathognomonic CT features that we will present also in this lecture. As you see from this table, these 10 diseases represent about 80% of those you will meet in your daily practice. Those represent 80% and such, and also those UIP, silicosis, sarcoidosis, lymphangitic carcinomatosis, and hypersensitivity pneumonitis represent more than 80%. So common things are common, and we want you to learn about common things. In the coming slides, we will present diseases that are common. They have no classifications or relations, but each one has its own features. Okay, so we will start with these. Sarcoidosis. The key findings in sarcoidosis is hilar and mediastinal lymphadenopathy, small nodules along with the bronchovascular bundle, and fissures in a patient with fever, weight loss, fatigue, erythema nodosum. There are what is called stages of sarcoidosis, of chest sarcoidosis. This stage doesn't mean that the patient proceeds from 1 to 4. No, they are called stages, but actually they are types. Stage 1 is just bilateral hilar adenopathy. Stage 2, lymphadenopathy plus pulmonary disease. Stage 3, only pulmonary disease without lymph nodes. Stage 4 is irreversible fibrosis. What are the common findings in CT and sarcoidosis? Number 1, small nodules having perilymphatic distribution. You remember these? Means that we have subpleural surface, fissures, interlobular septa, and along the peribronchovascular interstitium. This is typical. We have nodules that run along the fissures, pleura, and the peribronchovascular interstitium. Okay, this is a interlobular septum, okay, having beaded appearance due to presence of lymph nodules. So these nodules are distributed in perilymphatic pattern. Number 2, changes in sarcoidosis have predominance in the upper and middle lung zones. This is very important. As you see, the second thing is that we can see bilateral hilar lymphadenopathy and mediastinal lymphadenopathy. The high resolution appearance of pulmonary sarcoidosis is considered a great mimicker. It can mimic many diffuse infiltrative lung disease. 70 to 60% of patients with sarcoidosis have characteristic radiological findings. In 25 to 30% of cases, the radiological findings are atypical, and even in 5 to 10%, the plain X-ray is total. There are some uncommon findings in sarcoidosis, which under the name of fibrosis in sarcoidosis, an entity known as progressive fibrosis, which may lead to peribronchovascular, perihilar, conglomerate masses of fibrous tissue. The typical location of these lesions are in the upper lobes, posterior aspects. This is very characteristic, with displacement of the interlobular fissure toward them because there is fibrosis. Other diseases that can present with these fibrotic masses include TB, talcosis, and silicosis. We will see. This is an example of sarcoidosis. As you see, there is fibrotic changes involving the posterior aspects of the upper lobes with traction bronchiectasis. As long as these fibrotic masses are followed up, they migrate toward the hilum, leaving areas of emphysematous changes. Another uncommon presentation of sarcoidosis, what is called alveolar sarcoidosis. It appears as if it is a patch of ground glass opacity, but actually, if you look carefully, they are tiny nodules collected together in one area, giving this hazy appearance. Okay, tiny nodules grouped together. This is called alveolar sarcoidosis. Very rarely, it can present as multiple areas of consolidation, simulating bronchoalveolar carcinoma or pneumonia. So sarcoidosis in most of cases gives typical appearance, lymphadenopathy, and perilymphatic nodules. However, it can present by other presentations, and thus sarcoidosis should be considered in your differential diagnosis list because it is a great mimicker. This is the first great mimicker in our lecture. From the other uncommon findings in sarcoidosis, it can present by large nodules, galaxy sign. What is meant by galaxy signs? Grouped nodules or coalescent nodules surrounded by multiple satellites. Do you remember satellites in the lecture of solitary pulmonary nodule? This is called the galaxy sign. Sometimes sarcoidosis may have not very lymphatic distribution. It may present extensively along the bronchovascular marking bundles and may have centrilobular nodules as well. So these are the all features which makes the sarcoidosis the great mimicker. The disease number 2, silicosis, co-worker pneumoconiosis. This is a large subject that you can read a lot about its detail, but let us summarize the findings here. Silicosis and the co-worker pneumoconiosis are pathologically distinct entities with different histology resulting from inhalation of different types of inorganic dusts. The radiographic and high-resolution CT appearance of this disease are more or less the similar, so we grouped them together, silicosis and co-worker. It is important to realize that these diseases are rare compared to sarcoidosis and need a positive clinical history of exposure to these inorganic dusts. So we can find them in construction workers, miming workers, workers exposed to stand blasts, glass blowing, and pottery. Okay? What are the high-resolution findings in this disease? Small, well-defined nodules from 2 to 5 mm in diameter in both lungs. It loves the upper lobes. Nodules may be calcified. Centrilobular and subpleural in distribution. Sometimes they are random, so they may be centrilobular, random, or perilymphatic. Like sarcoidosis, it may present by fibrotic mass, which is called as progressive massive fibrosis. These masses may cavitate due to ischemic changes, and often we can see hilar and mediastinal lymphadenopathy, and some of them may be calcified with typical appearance of calcification, which is eggshell calcification or dense calcification. See images. As you see, patient known of previous exposure to inorganic dusts, the lungs are studied by numerous nodules. Okay, some of them are calcified. If you look to these nodules, they appear as if they are perilymphatic. This is what I have told you about progressive massive fibrosis. You see a mass-like lesion, but it makes shrinkage of the surrounding lung, crowding of the lung markings, denoting that it is a fibrotic, not a growth mass. Okay, and it likes the area of the posterior lobes of the posterior portions of the upper lobe. Disease number 3, lymphangitis carcinomatosis or lymphangitic carcinomatosis. What is this? Lymphangitis carcinomatosis is a hematogenous spread of cancer to the lung with subsequent invasion of the interstitium and lymphatics. It presents by cough and dyspnea in many cases. It could be asymptomatic. Lymphangitis carcinomatosis is seen in carcinoma of the lung, breast, stomach, so it can be seen due to intrathoracic cancer or extrathoracic cancer as a manifestation of metastatic disease. Sometimes you can see it as a metastasis from unknown primary. What is the stigmata, or what are the stigmata in high resolution CT, or the findings in high resolution CT? We can see irregular or smooth septal thickening of the fissures and thickening of the peribronchovascular interstitium. This is the perilymphatic region. The second thing that we can see these lesions as focal or unilateral abnormalities in 50% of patients. You can see hilar lymphadenopathy in 50% of these patients. It can be associated with pleural effusion due to pleuritic carcinomatosis in more than 50%. Let us see. This area, focal area, in where we can see thickened interlobular septi in addition to hilar lymphadenopathy. Okay? The finding is helpful. The finding of focal distribution is helpful in differentiating lymphangitis carcinomatosis from other causes of interlobular septal thickening such as sarcoidosis and pulmonary edema, which tend to be diffuse. But if the affection is focal like this, you should think of lymphangitis. Okay? Let us see the different appearance. Nodular septal thickening, smooth septal thickening, and you can see patches of ground glass in addition, or patches of consolidation in addition to these septal thickening. Also, the peribronchovascular interstitium can be thickened. Disease number 4. Cardiogenic pulmonary edema. Patients with pulmonary edema are not imaged usually by high-resolution CT, as their diagnosis is usually based on clinical and cardiographic or plain X-ray findings. Sometimes the diagnosis is not that straightforward, and knowledge of the high-resolution appearance of pulmonary edema can be helpful in avoiding misdiagnosis. What are the findings? Bilateral smooth septal thickening and ground glass opacities. Perihilar and gravitational distribution is predominantly in the dependent lung. You can see cardiomegaly and pleural. Let us see. As you see here, there are patches of ground glass opacities and with grading due to gravity. Okay, this is what is called gravitational effect. because it is fluid and the patient is supine in position. Number 2, there is a smooth thickening of the pleural fissure. Number 3, there are multiple, as you see, interlobular septal thickening, bilateral and diffuse, and more in the dependent areas, in addition to pleural effusion. And you can see cardiomegaly. Actually, this image, the heart is not that enlarged, but it may be internal defect within the heart causing venous congestion of both lungs. Edema can have a very unusual appearance and distributed very patchy. Some areas are filled with fluid as opposed to other areas of immediate vicinity may appear normal. Okay, patchy ground glass of gravitational. Disease number 5. Hypersensitivity pneumonitis. Hypersensitivity pneumonitis is also known as extrinsic allergic alveolitis. It is an allergic lung disease caused by inhalation of a variety of agents, such as those people, farmers, bird lung, those who are bird breeders, and also put in mind that acute hypersensitivity pneumonitis may occur due to allergy to certain drugs, okay, not only inhalation. The radiological and pathological abnormalities can be classified into acute, subacute, and chronic stages. But mostly high-resolution CT is performed in the subacute or chronic phase, because usually in the acute phase the patient is treated as if he has asthma, he has bronchitis, and so on, and usually he is not exposed to high-resolution CT for imaging. So we can see the patient in the subacute or chronic phase. Recently, hypersensitivity pneumonitis is reclassified into cluster 1 and the cluster 2. Cluster 1 is that including acute and subacute, and the cluster 2 includes the chronic hypersensitivity pneumonitis. What are the high-resolution features? Ill-defined centrilobular nodules of ground glass opacity in 80% of cases. Mosaic pattern of a combination of patchy ground glass due to lung infiltration and patchy lucency due to bronchiolitis and air trapping. So the key here is ground glass opacity, either centrilobular or patchy ground glass with air trapping. But in mind that history is very important. The patient may be a farmer, bird fancier, or he is exposed to certain fumes or certain drugs. Number 1, look for these. Okay, and for these are faint ground glass centrilobular nodules. Do you remember? Centrilobular nodules should be away from the pleural surface, okay, by 1 to 1/2 centimeter. Look again, we have a very faint ground glass opacities involving the centrilobular areas. You can miss this if you are not that experienced in CT chest, and if you didn't do MIP and MINIP, because they help a lot to detect these fine or faint or subtle centrilobular opacities. Again, subtle centrilobular opacities. Sometimes centrilobular opacities are more nodular in appearance, like these. Maybe ground glass or nodular like this. Okay. This is the mosaic pattern. You have areas of ground glass opacities and areas of air trapping. More obvious case, patches of ground glass opacities. The previous features are those of subacute hypersensitivity pneumonitis, but the chronic is different. The key findings in chronic hypersensitivity pneumonitis is mosaic pattern, areas of ground glass opacities, areas of low attenuation due to air trapping, in addition to signs of fibrosis and parenchymal distortion, usually like the region of mid-zone and sometimes. Let us see. What we see here, areas of air trapping, areas of ground glass opacities, and some features of lung fibrosis. There is some distortion of the lung parenchyma, but there is no septal and intralobular reticular thickening, indicating that these are signs of irreversible process. One of the famous signs described in chronic hypersensitivity pneumonitis called head cheese sign. You remember it? Areas of air trapping, areas of ground glass opacities, and distortion of the lung parenchyma due to fibrosis. This is a type of cheese or meat in Europe called head cheese sign. It contains fats, meat, fibrotic areas, and so on. In a history of chronic exposure to certain allergen, you can diagnose chronic hypersensitivity pneumonitis. The magic word in chronic hypersensitivity pneumonitis is the presence of areas of air trapping in addition to ground glass opacities, because we will see similar pictures but without air trapping in other diseases such as non-specific interstitial pneumonitis. Disease TB. I think all of you know TB can be primary or secondary. Okay, primary TB is the initial infection with consolidation, adenopathy, and pleural effusion. It is seen in children without previous BCG vaccination. Secondary TB, or what is called post-primary or reactivation TB, is characterized by the presence of pneumonia with reactivation, formation of lung abscess, and as it heals, it presents with nodules, cavitations, lung fibrosis. Both the primary and secondary pulmonary TB can spread through rupturing into a bronchus, giving endobronchial spread of infection. Okay, and this is characterized by the presence of 3 impact nodules, I will show to you. And both of them also can rupture into a vein and spread into the circulation, presenting what is known as miliary TB in any part of the body. Regarding the high resolution findings in TB, primary TB, patch of consolidation, ipsilateral hilar adenopathy, and pleural effusion. Later on, these areas will scar and calcify. We can see in older age a focus of calcification in the lung and calcified lymph node representing old healed primary TB. Secondary TB, it is characterized by consolidation. It likes the areas of the apices of both the upper loop and lower loop with cavitation. Endobronchial spread is characterized by 3 impact appearance. Miliary TB is characterized by miliary nodules. Miliary nodules means that it is 2 to 3 millimeter in size and having random distribution in lungs. Let's see. This is a consolidative lesion, area of calcification, presence of cavitation, and nearby areas of 3 impact nodules. This is typical for TB. Presence of 3 impact nodules in a patient known to have TB, it means that he has active inflammation or active TB. Miliary, as you see, tiny homogeneous sized nodules all over the lung. TB, secondary TB, can present by area of consolidation pneumonia, nodules, and fibrotic changes. The magic word to tell that we have TB is the presence of cavitation. Okay, presence of cavitation is famous in TB pneumonitis. Also, we have 3 impact nodules, denoting that this lesion has ruptured in our bronchus with endobronchial spread of infection. Again, the very characteristic appearance of 3 impact in a case of TB. It means that we have active TB. Some authors try to differentiate miliary TB from miliary metastasis. They said that miliary TB are usually of the same size and shape, but in metastasis, the lesions are of variable size. This may work in some cases, okay, but this is not a rule. Disease number 7, chronic eosinophilic pneumonia. There is a large group of disease called eosinophilic lung disease. In chronic eosinophilic pneumonia, it is an idiopathic condition characterized by filling of the alveoli with eosinophils. It is associated with an increased number of eosinophils in the peripheral blood. This is very important because to make a diagnosis of chronic eosinophilic pneumonia, the patient must have eosinophilia in his peripheral blood. In addition, the patient presents with fever, cough, waiting loss, malaise, and shortness of breath. The symptoms are often severe and last for 3 months, so the name comes from chronic, and the patient responds rapidly to it. What are the high-resolution findings? Peripheral consolidations of the upper loop predominance. It means the photonegative of pulmonary edema. You know, pulmonary edema usually comes perihilar and spurs the periphery of the lung. But this one affects the periphery of the lung and spurs the perihilar regions. That is what we say. Areas, patches of consolidation or ground glass opacities having the periphery of the lung, okay, sparing the central perihilar area. If this patient has peripheral eosinophilia, you can diagnose this because this picture we will see it in another disease in the coming part of the lecture. The differential diagnosis of chronic eosinophilic pneumonia includes organizing pneumonia, Loeffler syndrome, Church-Strauss syndrome, also presenting by serum eosinophilia, asthma, systemic vasculitis, and so on, and pulmonary infarcts, which comes at the periphery of the lung. Okay? These two patients are different. Both have peripheral patches of consolidation. Okay? This one is organizing pneumonia, and this one is chronic eosinophilic pneumonia. Differentiation has to be made on the basis of the clinical and laboratory findings because this one will have peripheral eosinophilia in his blood count, and this one will not. Also, the alveolar lavage, bronchoalveolar lavage, you can see a lot of eosinophils here, and here you will find something else, lymphocytosis or something like this, but not eosinophilia. Disease number 8. Pneumocystis carinii pneumonia. Pneumocystis carinii pneumonia, or sometimes called Pneumocystis jirovecii, which is the more correct name, is an opportunistic infection in immunocompromised patients. So the clue here that we have immunocompromised patients. Usually affect HIV patients, but put in mind that we have a lot of immunocompromised patients, not AIDS, such as those with transplant recipients and those on chemotherapy. We can see Pneumocystis carinii pneumonia in the patients. What are the high-resolution findings? Perihilar or diffuse ground glass opacities, thickened septal lines, presence of nematoceles or air cysts in 10 to 35% of cases, usually involving the upper lobes. The cyst may have bizarre shape and thick walls. Following therapy, these lesions eventually regress, resulting in either complete disappearance or residual nodules or scars. Due to the presence of cyst, pneumothorax may be seen in 35% of patients. This is the example. Immunocompromised patients presented by areas of ground glass opacities. Okay, sometimes nematoceles like this nodules, scarring. If the history of AIDS or immunocompromised state, you can think of Pneumocystis carinii pneumonia. From this, as you see, clinical is very important because imaging may have similarities in different diseases, but the clinical and laboratory data are mandatory to reach a correct diagnosis from these similar CT presentations. Disease number 9. ARDS, Adult Respiratory Distress Syndrome. It is a sudden, life-threatening lung failure requiring mechanical ventilation. It represents increased permeability of the respiratory, of the capillaries of the lung due to injury of the respiratory epithelium. It can be primary pulmonary or extrapulmonary. What is meant by this? Primary pulmonary risk factors includes aspiration, pneumonia, toxic inhalation, and pulmonary contusion. It means that the problem is an initial injury in the lung inducing increased permeability. But there is another type which is extrapulmonary ARDS due to risk factors outside the lungs such as sepsis, pancreatitis, multiple blood transfusions, trauma, drugs, heroin, and so on. Mild forms of ARDS resolve completely, while severe forms result in irreversible fibrosis. Extrapulmonary risk factors that result in ARDS, usually the manifestations are bilateral and symmetrical in both lungs. They are in the form of extensive ground glass and consolidations, having gradient pattern. As you see, the density of the opacifications is higher in the lower regions of the lung due to gravity-dependent gradient, okay, with bilateral symmetrical affection of the lung. The lungs appear very ugly, very white-looking and angry-looking lung. But in pulmonary ARDS, or primary pulmonary ARDS, the affection of the lungs are not symmetrical bilateral because there is an initial injury of the lungs such as pneumonia or something like this, and it has the same characteristic appearance. After healing of pulmonary fibrosis, pulmonary ARDS, there may be remained areas of mild lung fibrosis, usually affecting the anterior aspects of the lung. Okay, they try to explain that this affection or fibrosis in the anterior parts of the lung is due to the damage related to the barotraumas due to the ventilator. Usually the posterior aspect of the lung are more protected than the anterior aspects of the lung from the barotrauma effect of the ventilation. Let us stop here, and in part 2 speak about an important large group of diseases called idiopathic interstitial pneumonias, which have multiple subtypes. Please take a break.